Greetings, I'm Dr. Karl Nath, the Editor-in-Chief of Mayo Clinic Proceedings, and I am pleased to welcome you to the multimedia summary for the journal's May 2020 issue. There are 3 articles that have been selected as our Editor's Choice or Highlighted articles this month. Our Editor's Choice is an original article, Frequency of Medical Reversal Among Published Randomized Controlled Trials Assessing Cardiopulmonary Resuscitation, CPR. This article is authored by Ms. Diana Herrera Perez and colleagues from the Oregon Health and Science University in Portland. Medical practice and their guidelines, even those based on literature published in high-impact journals, are not infallible, as highlighted in recent years by the phenomenon known as medical reversal. Medical reversal occurs when a more recent and rigorous study gainsays the validity of a current medical practice and the studies upon which they are based. For example, a seminal study by Prasad et al. In Mayo Clinic Proceedings in 2013 evaluated original articles published in the New England Journal of Medicine over a 10-year period and showed that while 38% of articles addressing standards of care supported the appropriateness of current practices, reaffirmation, approximately 40% of articles refuted practices based on prior literature, medical reversal. In the present issue of Mayo Clinic Proceedings, Herrera Perez et al. Significantly advanced the field by examining medical reversal in studies involving cardiopulmonary resuscitation. The analysis was based on a previously published systematic review by Sinha et al. In 2016 of 92 randomized controlled trials of cardiac arrest occurring in and out of hospital in approximately 65,000 patients and published over a 20-year period, 1995 to 2014. Of these 92 trials, 16 were excluded by Herrera Perez et al., either because they did not meet the inclusion criteria or were indeterminate. Analyses of the remaining 76 studies demonstrated that the majority evaluated established practices, while the minority involved new practices. Notably, reversal of a current practice was reached in 58% of studies, with the majority of the reversals involving drug therapies or devices. Herrera Perez et al. Discussed reasons why the relative high frequency of medical reversals occur in CPR, including the possibility that the exigency of CPR may more readily incorporate new practices that are not rigorously evaluated. Broadly considered, the following concepts have emerged from the field of medical reversal. First, while experts may differ in their definitions, medical reversals are not simply low-value healthcare, but rather they reverse practice that was inherently devoid of any value. Medical reversals should be also distinguished from medical replacement, as the latter provides a more beneficial practice in place of an existing one of lesser but still tangible benefit. In contrast, medical reversals bespeak complete inefficacy or lack of benefit, or worse, the potential for harm of a given practice and the attendant compromised and misguided care of patients. A second major consideration is how do reversals arise. Medical reversals are generally driven by prospective, randomized controlled trials that incorporate more rigorous methodology, greater statistical power, improved trial design, and more relevant endpoints and controls than trials supporting the reverse practice. Reversals may also reflect weak clinical evidence to begin with, or the premature application of biologically plausible preclinical findings. Finally, another pathway for reversals arises from considerations percipiently elaborated by Dr. Ioannidis in a previous editorial in Mayo Clinic Proceedings. Namely, the majority of treatments and interventions in medical practice are incremental in nature, with beneficial effects that are hardly striking, and that interventions which substantively and consistently improve such incontrovertible endpoints as mortality are relatively rare. Given this relatively limited amplitude of benefit with most new therapies and interventions, entirely unforeseen vagaries such as those pertaining to changes in the targeted patient population, real-world effects, unexpected adverse effects, and unanticipated costs in aggregate and in time may cast a new and now unfavorable light on a once appealing and apparently supported therapy. Medical knowledge generally moves forward with small and not uncommonly tentative steps, and what may seem at a given time as beneficial, substantiated, and plausible may decidedly fall from favor in the light of subsequent analysis and added experience. The present study by Herrera-Perez et al. Highlights the need to scrutinize the validity of current medical practices and guidelines, to apply the most rigorous and best available evidence in informing such practices, and to be ready for course correction when indicated by subsequent data and knowledge. Our first highlight article is an original article entitled Participation Bias in a Survey of Community Patients with Heart Failure. The article is authored by Dr. Ermac Simsek and colleagues from Mayo Clinic in Rochester, Minnesota. In Arthur Conan Doyle's celebrated story on the disappearance of the champion racehorse Silver Blaze, Sherlock Holmes homed in on a suspect by reasoning that whoever was involved with the disappearance of Silver Blaze that night must have been very well known at the stable, because the stable dog never barked during the night. This key finding in solving the mystery exemplifies the general principle that a lack of a response, and not just a response itself, may reveal its own inimitable insights. This principle is highly relevant to biomedical research, and a remarkable example of it is provided by the study of Simsek et al. In the current issue of Mayo Clinic Proceedings. These investigators conducted a survey of patients with first-ever code for heart failure and who resided in southeast Minnesota. They assessed the characteristics and outcomes of those surveyed through the medical record database of the Rochester Epidemiology Project. In this survey, involving approximately 8,000 patients, the response rate was 43%, and on follow-up of some 1.5 years after the survey was conducted, there was a remarkable divergence in outcomes between non-participants and participants in the survey. Non-participants exhibited a twofold increased risk of death and an increased rate of hospitalization after adjustment for a number of relevant factors. Non-participants differed from participants in several ways, in that the non-participant group comprised a higher percentage of individuals who were female, single, non-white, less well educated, resident in rural areas, and with diagnoses of mental and psychiatric disorders. In contrast, non-participants were less likely to be diagnosed with cancer and associated cardiovascular diseases. The findings of Simsek et al. Have several major implications. First, they speak to the issue of participation bias as a limitation that may weaken the validity of epidemiologic studies. Specifically, Simsek et al. Showed that their survey did not capture information from individuals with heart failure with significantly different health outcomes. Second, as pointed out by the authors, the current literature describes a lack of participation in surveys associates with certain characteristics, several of which, such as, for example, lower levels of education being single, were also observed in their study. A lack of participation in surveys by patients may also reflect their lower sense of connectivity with the healthcare system or their greater sense of the burden of the disease and their treatment. Third, healthcare delivery increasingly emphasizes the importance of patient-centric care, the latter enabled by patient-reported outcomes. A lack of response in reporting such outcomes by significant subsets of patients would compromise patient-centric care. Fourth, while the basis for worse outcomes such as mortality and hospitalization rates in non-participants remains unknown, it is notable that almost 50% of non-participants decline to do so. This raises the issue whether such denial intimates a broader denial of disease and the extent to which such disease denial may be relevant to adverse outcomes. The findings by Simsek et al. Are important because they reach beyond a disease-specific heart failure survey to speak to the issue of participation in surveys in general. Finally, these findings show how important clues that advance epidemiologic research can be gleaned from those who do not respond or do not participate. Our second highlight article is an original article entitled An Institutional Approach to Managing the Opioid Crisis. The article is authored by Dr. Helena Gazalka and colleagues from Mayo Clinic in Rochester, Minnesota, Phoenix, Arizona, Jacksonville, Florida, and Mayo Clinic Health System sites in La Crosse, Wisconsin, and Eau Claire, Wisconsin. Recent articles in Mayo Clinic Proceedings have addressed key aspects of the opioid crisis, including, among others, the historical underpinnings and scope of this epidemic, the appropriate use of opioids for specific syndromes, the indications for medication assistance programs, and the need for a reasoned approach in balancing the risks and benefits regarding the use of opioids. In the present issue, Gazelka and colleagues provide an institutional perspective regarding the opioid crisis. This perspective draws upon the experiences, knowledge, and initiatives of the Mayo Clinic Opioid Stewardship Program that evolved shortly after a multidisciplinary work group was convened by Mayo Clinic leadership in 2016. Key findings from initial surveys undertaken by this work group indicated the need for consistency in the way opioids are prescribed, and that after surgery, doses and patterns of opioid prescribing range widely, with many prescriptions never needed or not appropriately discarded. The Mayo Clinic Opioid Stewardship Program targeted 4 main areas that include short-term and long-term prescribing, education, and the electronic health record-related initiatives. Groundwork to the development of institutional prescribing guidelines included a review of opioid guidelines formulated by the Centers for Disease Control and Prevention, as well as a review of relevant state legislation where Mayo Clinic practice is based, namely Arizona, Florida, Minnesota, and Wisconsin. Short-term opioid guidelines included provider responsibilities, including the prescription drug monitoring program, patient selection, and dosing. 3 aspects of these guidelines merit emphasis. First, as short-term prescribing by total morphine milligram equivalents, MME, may contribute to chronic opioid use, the guidelines included a daily supply as well as a general MME maximum recommendation. Second, the guidelines were based on tiers determined by the severity of pain anticipated from the type of intervention or procedure. Third, these guidelines were made available to providers in the intranet database of Mayo Clinic, namely Ask Mayo Expert. Long-term prescribing included patient selection, dosing, provider responsibilities and monitoring, and de-escalation. Educational strategies drew upon surveys and focus groups that assess understanding of opioid prescribing and utilize multiple conduits to provide information on opioid prescribing: email communication, Ask Mayo Expert, computer-based modules, CME content, and an opioid stewardship intranet website. Special attention was given to messaging for patients that utilize handouts, pamphlets, and videos. Public messaging was also pursued through community engagement and engagement with regional and national media. EHR-related initiatives and features were introduced to harmonize prescribing practices and patient monitoring with institutional policies. The article concludes with an overview of difficulties encountered, insights derived, and current initiatives in the Opioid Stewardship Program. Gazelka and colleagues are to be commended for leading, synthesizing, and effecting these institutional initiatives and policies, and for the clear summary of them in this important article. You can access these highlights and Editor's Choice articles free of charge during the entire month of May. When you visit our Mayo Clinic Proceeding website at www.mayoclinicproceedings.org, you will find links to our social media by clicking the buttons at the top of the home page to follow us on Facebook, Twitter, and YouTube. On our YouTube channel, you'll find full-length author interviews called Insights, 60 seconds video article synopses, and our Mayo Clinic Proceedings issue summary and author insights podcast recordings, which are available from our website on the home page as well as through iTunes. You will also find our online-only feature, Pioneers and Legends in Medicine, which are interviews with people who have made a strong impact in their field of study. You will see many news stories on our website that are based on articles published in Mayo Clinic Proceedings. And finally, you will see other free content and articles published online ahead of print. As always, we greatly thank you for your interest in and your support of Mayo Clinic Proceedings. We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our home page is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.